Endometriosis is incredibly common, affecting an estimated 190 million women and those assigned female at birth worldwide. It's a life-altering condition associated with chronic pelvic pain, impacting every facet of a woman's life, from her physical health to her emotional well-being. It can impact on a woman's ability to form meaningful relationships, their ability to study, and their ability to work. And despite the prevalence of endometriosis, it currently has no cure, and the path to diagnosis and treatment is often fraught with delays and frustrations, leaving women to suffer in silence for years. And these delays are not just inconvenience, they can lead to significant deterioration in quality of life, exacerbating the physical and emotional toll of the disease. One of the most critical issues in managing endometriosis, I think, is the current healthcare approach. Endometriosis is frequently treated as a series of acute episodes rather than as a continuous chronic condition. And this fragmented care model overlooks the necessity for ongoing comprehensive management, which is crucial for chronic conditions. For endometriosis, this approach is particularly inadequate. To truly support those affected by endometriosis, we must therefore change our approach. We need to establish appropriate pathways of care that encompass holistic and medical management. This means recognising endometriosis as a chronic condition that requires continuous and coordinated care. From diagnosis to treatment, discharge planning and follow-up, every step should be designed to provide consistent support and effective management of the condition. Recognising the gaps in our current approach, the NCEPOD review was initiated to produce recommendations suitable for quality improvement initiatives. This review aimed to identify areas needing enhancement and provide actionable guidance to drive improvements in endometriosis care.
I'm just going to hand over then to Alex, who's going to talk to you a little bit about how we did the study.
Between the dates of the 1st of February 2018 and the 31st of July 2020, we identified patients who were coded as having endometriosis and having had a laparoscopic procedure. In that period of time, 23,500 patients were identified, 1,080 were selected, and 900 included. We sent out questionnaires, and 3 major questionnaires were used to collect data. A clinician questionnaire, which was sent out electronically to the consultant gynecologist responsible for the care of the patient at the time of their index admission. An organisational questionnaire, which was sent to organisations and that was asked really about what they did and when they did it. A GP questionnaire, and this was sent as hard copy to the general practitioners, and the data on their interactions with patients with the endometriosis. So there you see that the clinician questionnaires, 623 were completed. We also had a group of reviewers, healthcare professionals from the care pathway for these patients, who met in the office here at NCEPOD and reviewed cases and then formed the opinions that have instructed the recommendations for our report. We also, of course, had a patient survey, which was an anonymous online survey, which has given us a lot of the very powerful messages from patients that we have included in the study.
Thank you. So, talking of messages, Katie, I'm going to hand over to you to talk through the main messages from the report.
Thanks, Miss. I'm Katie Malbon. I'm one of the clinical coordinators at NCEPOD. I'm a general paediatrician, but I do some adolescent gynecology. So our first acknowledgement and recommendation from that is that endometriosis is a chronic disease and should be treated as such. So unlike other chronic diseases, such as diabetes, there's no pathway for endometriosis. And we know that 52% of patients experience recurrence of endometriosis symptoms following their laparoscopy. And there seems to be this misperception that surgery fixes it. And in fact, one patient said, I thought that once it was removed, that was it. I was never told it would come back and that surgery wasn't a cure. So, and I think, many patients are feeling like that. And so there's no pathway and services aren't configured to manage it as a chronic condition. There are specialist commissioned services which are very surgical based. So they're for the deep endometriosis, and it's very much that is dealt with in a surgical manner, but there isn't the sort of follow up and the MDT approach that a chronic disease requires. And there's poor access to get back into services. So quite often women will just have to start again at the very beginning. So back to the GP. That leads again to long waits, misdirected referrals, and poor management of patient expectations. So there needs to be the resources and configuration of services to manage endometriosis as a chronic disease. The second recommendation is that endometriosis has symptoms and signs that need earlier recognition and timely management. So more than half of survey respondents felt not at all or not very listened to by their GP. And this came across time and time again, not just by GPs, but by healthcare professionals all along the pathway, that often women felt sort of fobbed off or not really taken seriously. And there seems to be a huge variation in the knowledge that GPs have. And though that said, there are some very good examples. So women health hubs seem to be very good at managing this and picking up the symptoms and signs, and then referring women in the correct way. But there just aren't enough of these women's health hubs. And there's something about educating patients themselves as well to know what symptoms and signs actually are endometriosis. So actually, there's something about educating younger women, adolescents, in what is normal and what is abnormal, so they know when to be asking the right questions. So the third recommendation is that endometriosis affects quality of life. All patients should be asked about its effect on their life. So what came across from the case reviews was that women just aren't being asked the questions. And a huge responsibility is it to ask those questions? Where does it start? Well, I think the answer is that it's everybody's responsibility along the pathway, from the GP to the gynecologist to the surgeon to other members of the MDT. There's often a pushback that it takes time to ask these questions, to ask more about quality of life. But actually, it's time saving in the long run. Endometriosis is such that, it as Andrew said at the beginning, it has a huge impact on women's lives. But, if they're studying, if they're working, on their family and on their desires for fertility. And so it can't be a sort of one size fits all approach to it. It has to be quite bespoke. And in order for that to happen, the questions need to be asked about that woman's quality of life, and more holistically about what they're doing in their life. That, this is a cohort of women where pain and poor mental health are among the most prevalent presenting comorbidities. So even more reason to be asking the questions, and to be actually offering them the support and services that they need, and managing their expectations in that as well. The reviews found that very few patients were referred to supportive services, and again, that's not surprising if the questions aren't being asked. So referrals to dietitians, to psychologists, to peer support were really very minimal. And in a disease that's affecting so much of a woman's life, you can see how important that really is. And the fourth recommendation, endometriosis requires holistic, joined up and multidisciplinary care. So after all, it's a chronic disease, and what chronic disease doesn't need that? We saw so many examples of siloed working, and particularly between sort of fertility services and gynecology. And it just felt like those specialties were not communicating very well with each other. And women were like being bounced in between services without anyone having an overall sort of joined up understanding or approach to women. And you can see here that reviewers found that only 11.2% of patients were formally discussed in an MDT meeting. And reviewers found that 13% of patients who weren't discussed should have been. So again, having that MDT approach is absolutely critical. It allows women to feel fully supported. It allows for parity of esteem. And as I said, the complicating factor here is fertility. And we know that often birth control is used to treat the symptoms of endometriosis. Well, you know, the desires for fertility need to be understood and discussed. And that needs to be shared amongst the healthcare professionals. So it's impossible to treat this disease as a single pathway. It's an interweaving of several disciplines, and joined up care is absolutely essential. So this was actually one of the case studies from the report, and Alex is going to talk us through it.
As you know, at NCEPOD, we recognise the value of specific case studies to highlight the problems. So this case was a 24-year-old woman who presented to her GP with heavy menstrual bleeding and pain. The GP treated her with a combined oral contraceptive pill. She had multiple visits to the GP over 3 years, with continuing pain, for which the GP prescribed analgesia, which included codeine. No further investigations were undertaken during this time. After 3 years, she stopped taking the combined pill as she wanted to get pregnant. However, 18 months after that, she was referred to fertility services by the GP as she was not pregnant and was experiencing worsening pelvic pain. The fertility services requested a pelvic ultrasound, which showed an endometrioma. They then referred her to local gynecology services, where she was seen 3 months later. She was listed for a laparoscopy and cystectomy, which happened 6 weeks later, and endometriosis was diagnosed. So our reviewers felt that it took around 5 years for this patient to be given a diagnosis of endometriosis and for appropriate treatment to be initiated. If the GP had suspected endometriosis at an earlier stage, then a pelvic examination and an ultrasound scan may have been performed sooner, leading to the patient being put along the correct pathway for an earlier diagnosis of endometriosis and therefore appropriate management.
And I'm sure, Emma, you've got many examples of similar stories. So I'm going to hand over to you and ask you to tell us why this report is important for patients.
Thank you, Marissa. Thank you as well, Andrew, for suggesting and championing this, and Alex and Kate for, Katie for doing the report, which is going to be of great value to the endometriosis community. And Alex just described a really common case. I think the only thing unusual is that it took only 5 years. I think that's the only thing that's unusual about that one. It usually takes a bit longer. And I think the other thing in there is around, by not diagnosing, we're not enabling people to make informed choices about their future, should they wish to consider fertility and things as well. And so I think what's been really exciting about this, and again, Katie's covered this, I'm just doing this from a patient perspective, is it is a chronic condition, and yet there just isn't this pathway. And we hear repeatedly through the survey that NCEPOD does and all our work about people having lots of delays, masses of wasted appointments, going to the GP multiple times, A&E, hospitals, to the wrong, going to colorectal or whatever it might be. And it just feels like if we could get this pathway sorted, it would only reduce suffering, as it says in the report, but it would also save on potential future needs because of progression of disease, and also save the NHS time and money in terms of resources that could be much better focused elsewhere. So hopefully with the report highlighting that, we'll do that. And certainly we speak to a lot of people who talk about having to fight for re-diagnosis if symptoms recur. And a very common example we get is someone's been diagnosed, they've had surgery, maybe 4 years later, pain's going back. And I was talking to someone just a few weeks ago, and she's been referred 3 times for an sexually transmitted disease test, even though she's saying, I'm not having sex, it's too painful, I'm not in a relationship, and I've got endometriosis, and she's still starting right at the beginning, and that's not helping her mental health or physical health, and it is wasting time in terms of accessing the care she needs as a young woman. So I think there's this having a chronic care pathway, as many other conditions do, where there's a recognition that it could come back, and if it does, that you can get the support you need. And linked to that is symptom recognition, and we do hear, and Alex just described a really classic example of people just not being believed about their pain, or just being told it's normal or normalised. We still get even in the last 6 months, people being told, you know, they should just man up. Always a lovely phrase, just man up. You know, people have periods, get on with it. For people who potentially have a serious disease, and the impact on someone's mental health of being told for an average, which the average diagnosis at the moment is about 8 years, 10 months to get a diagnosis in the UK, for being told for a big portion of that you're just being a bit of a wuss and you should be able to get on with it, and missing really important occasions. I was talking to someone who's not a bridesmaid for her best friend, which caused a bit of a falling out because she's not sure if she'll have abdominal bloating or be able to wear the dress that she wants to wear. So it has real impact on people's personal as well as their physical life. So the impact on that. And of course, access to treatments means a delay, less of delay to progress. Quality of life, clearly important. And I think we did a survey recently that showed that of the nearly 3,500 people who responded, over 50% had symptoms at or before 16 years old. So an impact really on education, and that can spill over to employment, your life course, and of course how you attain and achieve if you've not been able to get the education or do the work experience you want. And I think all of the, as Katie described, all the recognition of quality of life and a joined up care will help those people with endometriosis, and I would say other menstrual health conditions, because of course there's overlapping symptoms. It's putting people in the right pathway to get the support they need, but it will also very much reduce wasted appointments and potentially wasted interventions, which hopefully will save everybody time and money, as well as getting people the diagnosis they need. So really pleased to have been involved with NCEPOD on the report, but also really pleased to see the recognition of these areas, as Katie has explained. Thank you.
All those tools are freely available to you via the NCEPOD website.